It's this is such an amazing group of a meeting of the minds, singing voice people and voice therapy people and singers and teachers. And I just think that it is such a apropos topic to discuss with you all, kind of where those worlds collide and where they meet. So thank you so much for attending When Art Meets Science, Voice Therapy for Singers.
Yes, and
Uh,
as you'll notice, both Sarah and I love to just kind of have conversation as we're going. And so if you guys have questions, just feel free to chime in or write them in the chat, and we'll try to answer them as we'll go. We'll try to leave enough time at the end, but I know that Sarah and I can both be chatty, so we will do our best.
we are a little chatty, aren't we?
We are. Um,
These are our disclosures. We work at UAB, but we don't have any others. So
and this is what we will hopefully talk about today. And like we said, we both love a detour, so we may detour from some of this a little bit. But we're going to talk about our journey, talk about some myths that we've met along the way, and then talk about where art meets science, kind of where the voice teacher meets voice therapy, voice lessons meets voice therapy, and then hopefully answer some questions.
So a little bit about our journey. Elizabeth already sort of read our bios and let you guys all know where we came from and what we do. Um, I guess I wanted to talk a little bit more in depth about my story as a voice therapist. So I knew when I was 3 years old that I wanted to be a singer. I told my parents that I was going to be the next Madonna. But I was always extremely fascinated with how the voice actually worked. Like people were telling me to do stuff and I was like, well, why though? Like I was just so curious, like what does what you're telling me to do actually, how does that changing the sound of my voice? And so I was just endlessly curious, and I studied Joe Estel, her training methods, and was very into that. Did a little bit of classical training as well in college. And then I went on to be performing for about 10 years in musical theater mostly. Also some like pop and rock and contemporary work. And I always was just continuing to be so curious and feeling sort of frustrated with how little the people in my field knew about how the voice worked. And I would be like, well, don't you want to know? And they're like, no, I don't want to see. I don't want to know what's in there. And I was like, oh, I just want endless videos of my vocal folds and other people's vocal folds. Like, I just want to see in there. Um, so I was living in New York and I was really kind of just not enjoying my life very much at the end of that experience. And I was taking a dance class as I did just to keep up my dance skills. And there was this dancer who was talking about just after class, she was telling me about her vocal injury. She had developed mid-membranous lesions and had worked with a voice therapist to recover. And she said, I was a dancer first. I'd never learned how to sing properly, as she said, I didn't know what I was doing wrong. I just kept losing my voice. And she just talked about how much this voice therapist changed her life, and she was just tearing up telling me about it. And I was like, a voice therapist, like how do you become that? So, I like go home and I'm Googling, and I was like, okay, I need to just make this left turn and go into this because this is just what I have to do. And so but like a few months later, I was taking prerequisite courses and went to grad school soon after. And here I am. I'm so pleased that I was able to spend the last year studying under Dr. Edie Hapner, being her clinical fellow at the UAB Voice Center. I've learned so much about where art meets science.
And my path is actually somewhat similar. I, you know, after working for a number of years, during my time working, I had a really close friend that also had mid-membranous lesions, and they ended up having voice therapy and then having surgery and then having voice therapy again. And I got to kind of witness that process for her and kind of her road back to having a healthy and normal voice. And one of the things that always stuck out to me during her process is that when she first started having problems, to me, it just sounded like if I had never met her before and I had never heard her sing all of these stratospheric notes that are just so, so high, and then to hear how she was singing what she sounded like, it sounded just like she kind of technically didn't have those notes anymore. I would have never said, oh, this person must have a pathology. Like I couldn't orally tell that that was what's going on. The only way that I could tell was because I had heard her sing all of these notes for months and months leading up to that point. And that really got me interested in like what are these pathologies and how do people know, and like, are enough people going to voice centers to have voice therapy, or how can we as voice teachers identify this and know when to send someone to voice therapy? And that really kind of kicked me off on my journey. Yeah, and I'm excited to join the team here at UAB.
Yeah. It sounds like, oh yeah. And did Jacob tell you that he's about to start his fellowship? He's the new me.
Oh yes, I get to
And
be the
I
new
am the new
Sarah.
Desi, who is here as well.
All right. So now just and these are just myths that Sarah and I both experienced in our time as professional singers. And I'm sure that you all have experienced many of them, and maybe we'll be repeating some, and maybe we'll be telling you some things that you already know. But I think this is just kind of important to talk about.
It is. I think this one really gets me. The the myth that we know absolutely everything about how the voice works is so pervasive, and it's like you get people on two ends of the spectrum, right? People who act like the way that the voice works is a complete mystery and we have no idea and there's no point in knowing anything about the anatomy or the physiology of how the voice works. And then you have people who think that we know absolutely everything and that we can just like nail it down exactly, and if we move this part, we move this part, we move this part, it's going to make exactly the sound that we want, and ta-da, it is this like exact, that's why I put a cookbook, because it's like a recipe. But everybody's bodies are just different, you guys. Like there are so many mysteries. How many times have we listened to a singer, and even having, read everything that we want to read, and like, two very experienced people listening to the voice will say, oh, I think that they're doing this. And the other person might be saying, no, I don't think so. Do you think that that's more of a chest voice? Like, or are they altering the vocal tract, and they're in a head voice, but they're using twang and they're masking it. There are people that were just like, what are they doing? We have no clue. And even if we look at the voice with the technology that we have, the stroboscopy, for anyone who's not experienced this, you have the scope camera either in your mouth or down your nose, and there's a special little light that you hold up to your neck. It's a special microphone that tells our light how frequently to flash to make this sort of flip book image of the movement of the vocal folds. And it's amazing technology, and thank goodness we have it, because it informs everything that we do at the Voice Center. But even that, it's a representation, right? And it's also an exam, so people might not be doing what they're doing on stage. So there's just so much that we can't see. We see the surface of the vocal folds, but we don't get to see underneath exactly every single second of the way. We can't like touch and feel how that's going. And when we do a surgery, they're asleep. So we can't really, feel what they're doing then either. So there will always be mysteries. As curious as we are, I think that's what makes the voice so beautiful and exciting.
Yes. And as we know, there are many immutable truths, but they're about singing and about voice. But it is also so true, Sarah, that you already said, everyone experiences their voices differently. So the way that one person may sing something may be completely different than how another person may sing it. And both are completely right and good. So yeah, I love this myth.
This is my personal favorite. Raise your hand if you have been told to breathe with your diaphragm in a voice lesson. See, everyone with their camera on and even people without their cameras on, have been told to breathe with their diaphragm. I cannot tell you how many people I have asked when they've told me, oh, I asked them, okay, so tell me, what do you know about breathing? Like, as soon as, if I'm working with a singer in voice therapy, I just want to know where we're coming from, like what experience do you have? And I'm like, do you know where the diaphragm is? And they have no idea. They have no idea where it is. They think that it is like the outside of your abdominal wall or something, so that when you breathe in, it expands. So here we are to dispel the legend, the myth. The diaphragm, I like to think of it as like a squishy shelf, and your lungs, they sit on top of it, and your brain is talking to it all day long, and it's telling it to go down so that you create a negative pressure, and that it'll take in air and your lungs can expand and have room to expand. And sometimes, that can displace your digestive organs. So that's what it looks like, that belly breathing, right? But if your diaphragm is not going up and down via the involuntary message from your brain, you are dead. You cannot breathe without your diaphragm. Just like cracks me up. You can't. You could allow your diaphragm to descend more by relaxing things in your abdomen. We can strengthen the diaphragm with strength training, with resistance training, ideally, but you can't breathe without it. So don't obsess. I always tell my patients to allow the diaphragm to do what it needs to do. Don't force it. Let's allow it to do what it needs to do.
Yes. Very well put, Sarah. And I think a lot of times when people say breathe from the diaphragm, some of the things they may be meaning are, release the lower abdominal wall, or expand the intercostals, expand the rib cage, maybe release some of those lat muscles in the back and expand the back muscles. I mean, I think that's very complex to say, though, so it's a little easier to say breathe from your diaphragm. But if we can just internally kind of process that information and translate it into, okay, maybe I need to release my abdominal wall a little bit more, and allow those abdominal muscles to contract slowly as I'm exhaling, or as I'm speaking, or as I'm singing, not forcefully contracting them, but allowing them to contract.
Yeah, it's kind of like a really long game of telephone that the last person has been a lot of voice teachers on this earth, where they're just like, I remember somebody told me this. I don't know exactly what that meant. Yeah.
Sarah has already beautifully described how the diaphragm works, but the diaphragm, the lungs, those are the things that power up the voice. So as you take a breath in and then you exhale that breath through the vocal folds, which is the source of the sound. And then those vocal folds vibrate, and that sound travels through the resonating cavity, so through the oropharynx, the pharynx, the nasopharynx, and that resonating tract is really what makes your voice sound like you. I once heard that if you were to lop off your head kind of at the level of your vocal folds and there was no resonating space above it, it might sound a little bit kind of like a kazoo. But then because of all those cavities that the sound kind of bounces around in, that gives each person their sort of unique sound. And it's really how we identify people, is by listening to their voices.
And we also, well, here's a video of my vocal folds.
Yes, this is a video of the lovely Sarah Hoch and her larynx. And before I show you this video, I just kind of want to tell you what to watch for. She's going to sing a note that's kind of soft, and she's going to sing it with a straight tone, and then she's going to add vibrato to it. And I just kind of want you to just pay attention to the differences in what you're noticing with the pharyngeal areas.
So it's breathier, there's more of a gap, and then all that shaking is the vibrato. All breathy, but adding vibrato in and out. Okay, and then
I just think that's such a great video that shows kind of how the pharyngeal area, how that resonating space is affecting the way that her voice is sounding.
Mm-hmm. And as you could kind of see, because I'm in more of a head voice, and we'll talk about that in a second, the vocal folds they're long and they're not adducting super tightly. So it's more of an open phase dominant cycle.
Yes. Which brings us to this. And I'm super grateful that I think that we at like voice pedagogy is moving away from this myth. I think that it fell into fashion that chest voice was bad at some point in time, and now everyone's realizing that that is false, that our chest voice is a big part of our voice, and it plays a role in the whole voice. So there really are kind of three distinct registers in the voice. So the first, chest voice, which is TA dominance or thyroarytenoid dominance. That's the dominant muscle for phonation. And then when we move into head voice, we have more of a CT dominance or cricothyroid dominance. So the TA muscle is an intrinsic adductor muscle of that brings those vocal folds together, and the CT muscle is the muscle that lengthens the vocal folds to change pitch. The idea that you can sing a note without the involvement of both of those muscles is completely false. So every note that any of us sings is a mixed note. So you may have different ratios of mix involved. However, every note has both TA and CT involvement. So for us, when we're working with someone in voice therapy, oftentimes we'll notice a change to the voice at those periods or those places in the voice where we're transitioning from one to the other. So oftentimes when a singer comes in for an evaluation, we may give them a task that requires them to transition from one to the other smoothly to see, how that transition is happening. But yes, and I think our next slide here is Sarah showing us kind of the difference between the two. You already mentioned a little bit, right, about how when we have a TA dominant phonation, we're coming together, the vocal folds are coming together a little bit more like this. So we always see a top-down view, so we see the vocal folds this way, but they really are coming together this way as well. So as we're in chest voice, more of the bulk of the vocal fold is going to come together like this. As we move into head voice, they're going to thin out a little bit and they're going to come together just like this.
And that's where that Joe Estel terminology is derived from, right? It's the thick folds versus the thin folds for chest voice versus head voice. I think it's interesting.
Yes, and you can do that on one note. If you just hold one note, most of the time you'll start in chest or start in head voice, and then you can get really, really loud and you'll move all the way into chest voice. And so that will be kind of moving through any sort of combination of chest and head voice just on one note, which we will kind of see here.
I alternate back and forth. I didn't know the assignment.
Here we are belting. Same note.
Okay, I'm going to play it one more time, but you'll notice when she's belting, there's much more of a closed phase. And so the vocal folds seem to come together and stay together longer. When she's in her head voice, in her softer voice, you'll notice that there's more of an open phase. So there's more of a gap between the vocal folds more of the time. I'm just going to play it one more time.
Here we are belting. Same note.
You have such a beautiful voice, Sarah.
Thank you. I think this is another one of those moments where I'm like, oh, Joe Estel, what would you think? Would you think that was a thin folds or would you think it was a stiff folds?
I don't know.
Very interesting. I don't know. Once again, we do not know everything about the voice. There is no perfect exact recipe. This myth, oh man, I think that this myth is more of a pressure that we put on ourselves as singers. Like, okay, I sang that high note once perfectly, like, yeah, I did it. I hit my high C. And so now I should be able to just do it that way all the time. And I'm going to be doing it all day. Perfect.
I have done that. I mean, I know that every singer has been like, oh my God, I sang that note so perfectly in my lesson. Now let me run down to the practice room and sing it again 400 times. I know I did that.
Nobody told us not to. We didn't know. But I love sports analogies. I always do. I think that the idea that someone could learn the motor pathway to do something efficiently and easily that's really athletic, like sinking a free throw shot, and then that they should be able to stay on the court and just keep shooting with 100% accuracy for the rest of the day is insane. We would never expect that of a basketball player. So why are we expecting it of ourselves, right? It takes practice. And the principles of motor learning tell us that it's better to do that free throw a few times, be like, okay, yeah, that was good. That was good technique. Come back a few hours later, do a few more. Come back a few hours later, do a few more. Then let's come back tomorrow and let's do it again. I'm going to do that a few times. A few hours later, we're going to do it again, a few more times, right? That's how you perfect, or not perfect, because there's no such thing as being perfect. That's how you improve your motor learning pathway and become more efficient, more accurate. And then also you have to take into account the idea of endurance and strength. So just because you are able to hit that high C doesn't necessarily mean that you are going to be able to hit it 12 times in the span of a 2-minute long piece today, right? And if you were learning how to do a really good squat with really good form, we would teach you the form, right? And you'd learn how to do that good squat. And we'd say, okay, yep, make sure your knees are over your toes, oh, you're arching your back a little bit here. And once we got that form right, we wouldn't be like, okay, and now we're going to add 100 pounds, right? Like that would be nuts. We would gradually increase your weight, maybe gradually increase your reps. We would gradually increase the amount of time that you're able to hold it. So singing is motor learning. It's a motor task. Gotta build skills, gotta build strength, gotta build endurance.
Yep, that's really well said. It is both a coordination building and strength building task. And it's also why it's so important. Like if you're learning how to do a squat, you learn how to do one with really great technique so that you don't injure yourself when you start moving towards the fatigue building portion of the exercise and of the workout program. So as you're learning to do the squat, making sure that the right muscles are working, the targeted muscles are doing the work instead of other muscles that you may not want to be involved that may lead to injury. And then once that technique is really well established, you can start slowly introducing the fatigue resistance part of the training program. And by approaching singing in a sort of similar way, so like if we are going to give someone a singing task, like a register transition, we would want them to practice the coordination of that transition. And then as the coordination builds, we can change the complexity of the task to be one that is maybe more exuberant or more targeting a fatigue resistance sort of goal.
Oh, Jacob, tell us about this one. This one just breaks my heart.
Oh my goodness. Okay, so this happened to me, and I think this is something that does happen, unfortunately, commonly. At least it happened to me. I will never forget. I was at a young artist program. I was supposed to sing for a visiting artistic director at another company in a master class. And I got this horrible, horrible cold, and it just it would not go away. And I'll never forget that the director of that program told me, Jacob, if you can't sing through a cold, you're not really going to, it means you don't have very good singing technique, and you're going to lose a lot of money over your career. And it's going to be a big challenge if you never learn how to sing through a cold. And it was really kind of devastating for me in a number of ways, because one, I'm being told that I'm going to not make money because I get a cold, and two, I was told that I'm a bad singer because I can't sing when I have a cold. So it's just that was something that I've carried with me for a really long time, and I ended up making a terrible decision and singing while I had a cold, and it was terrible and awful, and I just felt terrible about myself for quite a long time.
I just think I can't even imagine how misinformed it is to think that you could make a physical change to all three parts of that power source filter model that we showed. Your lungs maybe are not able to have the same vital capacity. Your vibrating source maybe swollen and red and inflamed and prone to little vascular events, and your resonating chamber is all swollen and full of gunk and a different shape, and maybe a different shape one morning than the next, and to say, why aren't you able to do what you need to do? Why can't you do that? That's like if someone sprained their ankle and you were like, well, you should still be able to run a marathon. Back to my sports analogies.
Yeah, you're just like bringing them out.
I know.
Um, uh, yeah, and we know that each cold is a little bit different, and each person kind of experiences a cold a little bit differently as well. And so maybe some people are more prone to being blessed with their cold just staying up in their sinus area and it not traveling down and causing any sort of vocal fold swelling. And I am so happy for those people. But I'm not one of them. I know that every time I get a cold, it travels right to my throat, and it's really hard to sing, which is why I think having access to or knowing about a simple little vocal fold swelling test can be really helpful. So,
The vocal
common
fold
one
swelling
that we
test.
use to what?
Is it, the vocal fold swelling test? Just
Yes.
raise your hand if you are unfamiliar with the vocal fold swelling test. Is anybody? Oh, great. Then this is going to be useful. I love it.
Yes.
Jacob, you
So
want
all
to tell
you
us
want
about
to
it?
do, yeah, all you want to do is sing something in a high, soft voice. So for men, singing it in falsetto. For women, just singing in at a high pitch. And you'll want to, when you're healthy, figure out where is a comfortable place so that when you are maybe not healthy, you'll be able to compare the two. Um, but singing like happy birthday at a high pitch in a soft voice. Happy birthday to you. Happy birthday to you. Happy birthday, dear. Oh, it's my dog's birthday today. Atlas, happy birthday to you.
It
And if
really
you
is his
notice,
birthday.
if you notice that it's that your voice is cutting out sometimes, you might have an onset delay, or if it's just more muscularly effortful for you than normal, you may be experiencing some vocal fold swelling, and it might be a good idea to rest a little bit.
Yeah, especially if you feel like you can only achieve that note with like a really increased amplitude. So like really just pushing more air through, getting things really going. That's why the quiet is a good test. But then what happens if you do have swelling? I think, Lordy Lord, there is so much stigma around voice disorders. There is so much fear around like, I think my vocal folds are swollen, and oh my God, like I have nodules, and oh my God. And if we hear that someone has had a vocal voice disorder at all, somebody especially in like a professional singer, like when we all have heard of, we all know these, right? Like why am I forgetting her name? Good Lord. Sound of Music, Mary Poppins.
Oh,
Julie Andrews.
Thank you. I was like Julia Child. That's not right. Julie Andrews, um, Adele, John Mayer. We hear about these people having these vocal cord injuries, and we're like, oh God, they must have terrible technique, and there's like this cast of shame over them. And as a result, people who are on Broadway, people who are professional voice singers, they have these injuries and they hide them, and people don't talk about them. And I think there is a little bit of a change in that department where people are starting to like come forward and be like, I had this, and I got better, and that is so great. But I think that we all can do ourselves a favor and stop it with the stigma. If you are sick, if you are injured, that is a part of life. You are a human. Professional singers are not robots. Like any kind of singer, anyone who sings for fun or is pursuing singing or any kind of professional voice use, you're not a robot. Things happen. And if you were a football player, they would talk about how you tore your ACL or whatever, or pulled a hamstring. Let's say pulled a hamstring, something a little less scary on the field. And they would say, they're out for such and such amount of time, but we wouldn't say, oh God, they're a terrible football player because they pulled that hamstring. They're terrible. They have awful technique. They're never going to play again. And their worth has diminished. They should be ashamed. We wouldn't say that. And why do we say that about singers? We are using our voices at a high intensity level. Things happen.
Yes. And just like that football player is probably much more likely to experience sports related injury than I am at this point. People who are using their voices professionally are much more likely to experience an injury related to their voices. And the more we start talking about it, I think the more people will seek help sooner in the process and be able to, maybe avoid having something really difficult happen.
Absolutely. So I feel like we've talked a lot about, how art meets science already in this discussion, but I think that, like what Jacob said, how do we make people seek out help sooner? How can we be better open communicators between voice instructors and voice therapists and laryngologists and everybody who works with the voice, so that our students and our patients are getting care and getting help and getting training more quickly and with better quality sooner. And I think that's why this group exists, so that we have contacts of people that we know have this shared set of knowledge, so that we can reach out and say, hey, I have somebody that I really think they might need you. So can I send them your way? And we say, yes, definitely. And so we want to talk a little bit about what that relationship looks like.
And so the first part of that is kind of like talking about what is the difference between voice therapy? Did my slide change? Is it going?
No, it seems like it tried. There it is.
Oh, there we go. What is the difference between voice therapy and voice lessons? And of course, there is lots of crossover, lots of similarities, but I think the overall goal of both of them is a little bit different. So with voice therapy, we're really trying to recover function that has been lost, whether it is in your speaking voice or in your singing voice. So we're trying to rehabilitate the singer to where they were before whatever it is that happened to them, so that their voice returns back to a baseline. With voice lessons, we're kind of wanting to expand the overall sort of vocal prowess that someone may have. So their overall technique, we're building on top of a technique that's already established, and most of the time at least we are hoping that we are working with a healthy voice that is without any sort of pathology.
And I think that there is some crossover, like there are things that we do in both. Like, are we doing lip trills in both sometimes? Yes. But are we doing other kind of semi-occluded vocal tract exercises? Are we maybe working on register changes? Yes. But the difference is that someone in voice therapy has some kind of pathology, or they have a muscle tension dysphonia issue that is sort of beyond just regular voice lessons. Like, it's become pathological.
Right.
And
yeah, and like the overall goal, like the goal of those exercises in a voice lesson is to expand the voice, just expand the voice and what it can do. Whereas in voice therapy, the goal of those exercises is to regain function, and they're just used a little bit differently.
Yeah. I have an interesting a patient that I worked with that I think illustrates this really well. I worked with a singer who had mid-membranous vocal fold lesions. And at the time that she saw me, she was doing 8 shows a week. And, was really struggling during the shows. And so during our therapy sessions, did we do a little bit of singing? We did. We sat down at the piano, we had her score out, and we were figuring out, how can we do this music in a way that is the least phonotraumatic? How can we reduce our our compression of the vocal folds, right? So we're choosing different registration. We're trying to work to focus a little bit more on our resonance rather than like a really loud phonation, and optimizing resonance, and creating new pathways for she's set the way that she's singing this based on the style of the show, right? And we need to change that, because we need to set it so that it still works with the style and it's not totally inappropriate. She doesn't want to lose her job, but she also needs to be doing this in a way that's going to promote healing. And then we're also talking about how can we promote healing outside of the singing. So we're working on vocal budgeting, like what are times of the day that you can stop talking? Like, do you have periods where you can be totally silent? We're talking about, steam. We're optimizing her speaking voice so that it's reducing phonotrauma. We're working on lifestyle changes for that time to promote healing. So there is crossover. We're singing, but it's not a voice lesson, right? It's different.
Yeah. So then when do we refer to a voice center? And these are just some basic guidelines. So when you're working with a student that has a voice change, either in their speaking voice or in their singing voice, that lasts 2 weeks longer than the resolution of an upper respiratory infection or a cold, then that is a good time, or a good time to send them to the voice center to get checked out. And it begs the question, what is a voice change? So what are these changes that we're talking about? It could be increased vocal fatigue. So maybe they sound exactly the same as they've always sounded, but their voice is just inexplicably getting tired a lot faster. So they sound the same, but they're just having all of this vocal fatigue. Maybe their vocal range is reduced or changed in some way. They don't have access to low notes that they used to, or they don't have access to high notes that they used to. They have reduced vocal flexibility. So maybe some sounds that they're used to being able to make comfortably all the time, they can no longer make, or just having access to dynamic variability. So maybe they can sing some of these notes really loudly, but they can't sing them softly anymore. Or they just have trouble controlling their voices or controlling the pitch of their voice. And then also, obviously, the most obvious one, I think, is any sort of chronic roughness or breathy vocal quality that they may have that lasts 2 weeks longer than the resolution of a cold or an upper respiratory infection.
And also, I think it's important to note that if one of your students is just somebody who just, gosh, they lose their voice a lot, like they keep losing their voice, like they come back and it has nothing to do with a cold, right? They lose it and then it'll come back, and 2 lessons later, they come to see you, excuse me, and they've lost their voice again. Is there some sort of phonotrauma going on? Is there like a muscle tension problem? Is there something in their speaking voice that they're not doing optimally? Their longevity just isn't, you're a little worried about it, send them our way. And also, of course, if your student experiences a sudden voice change, generally that would indicate some sort of a vascular event, a little bleed. So they should come in right away. And generally speaking, when we hear about singers, especially like anybody at a high level that you're working with that has experienced a sudden voice change, have them give us a call and we will get them in fast. we get it. We're those people. So yes. This is an interesting one, Jacob, about the cough.
This one actually, it kind of cropped up in my life in a sort of unexpected way, and that's supposed to say 2 or more months, not 2 or months. But I was noticing a student that I was working with, and they're a very accomplished singer, have a doctorate degree, singing professionally, lots of places, and I was having a lesson with them recently, and I just noticed that they were kind of suppressing a cough, and I would have them do a vocal task, and I just noticed there was hesitance, and I just decided to ask, hey, what's going on? Are you okay? Do you have a cold? And they ended up telling me about this cough that has been kind of on and off that they've had throughout their lives. And they talked about how when they're using their voice a lot, that the cough worsens, and they teach English to lots of students throughout the day, so they're constantly talking. Or when they're singing a lot, that they notice that their cough is worse. And often after they have a cold, they'll end up having a cough for 2 or 3 months after the cold's already resolved. And they kind of said, I can't tell you how many lessons, how many times I've been in a lesson, and it's just been completely ruined by this cough. I can't not cough while I'm singing. And only because of just my bit of experience in voice therapy, I started asking myself the question, I wonder if there's some way we can maybe find an easier speaking voice for this person and maybe reduce the urge to cough a little bit. So I did some voice therapy techniques with them, and uh, the best part of this whole story, I think, is he started saying, "Oh man, my voice is so much higher than it was. I feel like I'm speaking a fourth higher than I was speaking before." And I was like, "No, you're not. You're speaking at exactly the same pitch." And they just would not believe me. So I took 2 speech samples with my phone, and one was maybe 3 hertz higher than the other one, which is not even a half step. So literally the same pitch. And they were like, "Oh my God, my mind is blown. Have I always, needed to, is speaking always been this easy? Does everyone speak this easily like this?" And we talked for like an hour, and they said that maybe there were 2 or 3 times they had the urge to cough, but it was so much easier to kind of repress that urge to cough. Now, I will say, when I see this person again, I'm going to ask about their cough. And, if it's completely resolved by that, short little thing, then great, lovely. But if it's something that lingers, it's definitely something that I might advise them to go to the voice center in the city that they live to be checked out, because there are treatments for this. And it does seem to be affecting his life pretty significantly, and especially his singing voice and his singing training. So this is just, I don't know, something that cropped up in my life that I was not expecting. But I wonder if maybe some other people may have had the same sort of experience.
And I think it's so, I mean, had you not had the training that you had as a speech pathologist, you wouldn't have even known that treating a chronic cough falls within the realm of a voice therapist, at a voice center. So chronic cough, paradoxical vocal fold motion, if you see anybody that's like, gosh, sometimes like when I'm really upset, I just have this strange, like stridorous breath where it's like, and I can't breathe right, or we treat those things. So send them our way. A chronic cough being like, dry and it's lasting for 2 months. After the resolution of other cold symptoms, or just one that, we see patients who've been coughing for 40 years. It's really, really fascinating to work with those patients. But also I feel like anytime you just are like, there is something weird going on with his voice. Like I've thrown my toolbox at this person and they are struggling and I'm stuck. Don't beat yourself up. Maybe there's something medical going on. Send them over. Let's have a peek and see where they're at, especially, just to know what their baseline is. I also think every singer should know their baseline. Every singer should know what their vocal folds look like. If somebody, has a little prominent vessel on their vocal fold that is there all the time when they're at baseline and it's perfectly fine and they feel really good about their voice, then they should know that. So if they start having a voice problem and they go in and they are like, "Oh my gosh, I've lost my voice," and the doctor sees that there's this little prominent vessel and they don't know that was there when their voice was perfectly healthy and wonderful and normal, they might think that might be at play. Or they might we'll pull up the 2 exams side by side and we can compare. And that is such a valuable tool. So just establishing care with a voice specialized, a laryngologist, not just any ENT, come to the voice center. We have special tools. Somebody asked me, somebody mentioned in the chat, what is the preferred way for a voice teacher to refer a student who has chronic issues? We are kind of working on setting up that pathway right now. I don't know if Edie can speak more to that. At the moment, if you were to call our access center, just our regular access center, and you talked about a singer, I think, our scheduling people know to talk to us, hopefully. But also we have email addresses, so we can and until that pathway is very, very directly and perfectly set up, you can always just reach out. On the flip side of this, I've been having some interesting experiences lately where, I'm working with singers in therapy who maybe some of them have not really had many voice lessons before. And they don't know a whole lot about, technique. And I always get to this point of, okay, is this therapy session morphing into a voice lesson? Are we moving past where this is a pathological problem? And so I've been kind of asking myself and trying to learn more about when I should be referring my patient onto a voice teacher. When are they appropriate for discharge? When can I say, all right, I think you're ready for voice lessons. We have rehabilitated and now it is time to habilitate. And I feel like these are some little guidelines that I've created just for myself. They're still growing and tweaking. But when a patient is independent in voice therapy strategies, so they're able to navigate whatever this pathology is, or just when they're healed, like if they had lesions and they're gone, or they've reduced significantly in size, and they haven't had a voice teacher in the past, I might send them on to a voice teacher. And I would really like to send them on to a voice teacher who is familiar with working with people with vocal fold pathology. Oh, that's some loud thunder. I don't know if you guys could hear that. And when I feel that my therapy session they're starting to morph into voice lessons, and I'm starting to teach them how to make sounds that they could never make before. And also just if I feel like more frequent technique and repertoire focused work would better benefit the patient. And that's a little subjective, but I have had a patient that I worked with recently who I felt like really captured this experience for me. This patient had a vocal tremor, and he was very, very extensively trained. Had, like a master's in voice and had taught choirs and these things for a long time. And he was dealing with this tremor and he just couldn't really navigate it. So we were working on ways to sort of like, how can we use what you have? I mean, I can't make your vocal tremor go away. He was not open to getting Botox, but we realized, how much tension he was using to compensate. So we were trying to release that tension, sort of allowing the vocal tremor to do what it did and, just release the vibrato. And also noticing that his vocal tremor was worse at the end of a breath group, which is pretty common. So when he was reaching the end, so working with him to be like, okay, you could get away with expelling a lot of air in sort of an expressive way at the beginning of phrases and really singing on that reserve at the end of your capacity, right? Maybe before when you didn't have this, but now oh man, you do so much better. And that tension really, really it's easier to keep at bay when we are working with the breath, when we are working with a slightly more Germanic style of deflation, where we're really kind of controlling it. So we did inspiratory muscle strength training. We were working on just endurance building with the breath so that he had the best breath support possible so that this tremor at the end of the breath groups was impacting him less. And we worked on releasing tension. And at a certain point, I was like, we were working on a song because we're working on carryover of this skill, and he's singing a song. And I watched him be like, nope, that wasn't what I wanted to do, and fix it. And he was fixing it on his own. And I said, this is the moment. He's ready for voice lessons. He and I are done. Like, he's graduating. It was a really cool moment. It kind of gets me a little teary because he has such a beautiful voice, but, like finding that moment is so gray and it's so difficult. And I'm still learning it myself, when to discharge a singer. But I only have so many sessions, and there are people with other problems that are just at the beginning of their journey and they need help. And sometimes it's time for them to move on to voice lessons, and finding that moment it's special.
I think also, and I literally just thought of this right now, but as a singer, who is working with a voice therapist and who is navigating maybe that time moving from voice therapy to working with a teacher, maybe a teacher they've worked with in the past or a new teacher, advocating for yourself with that teacher and say, hey, I'd love for you to speak with my voice therapist just so that you know what we've been working on, sort of the things that have helped, the things that maybe won't help. And we as voice therapists would love to speak with voice teachers just because it's such an important passover of both care and training for that singer. So I think if we as singers can advocate for ourselves in that way and just say, hey, here's the contact information. I'd love if you could just call and give this person a few minutes of time. I think that would be a really meaningful thing to do.
Yeah. And if you do send your patients on to your students onto us at the Voice Center, I keep mixing those words up, which isn't great. um, asking them, hey, like, how do you feel about me having an open line of communication with your voice therapist?
Yeah.
Like, just figure it out. Like, if they would rather it be private, like, everybody has their preferences. So we have to respect those preferences. And I ask the same question. How would you feel about me talking to your voice teacher? And if you don't want me to, but also, like, if you got time, I mean, I know it's kind of tricky, but sometimes voice teachers go to voice therapy sessions with their students, if they're just like, maybe this is something that will be useful for our journey together as a student teacher relationship. The issue of billing can be tricky, like who's charging for this time, because it is a medical service. But I would love to see all y'all at the office. Come be your students buddy in therapy. Be pretty neat.
But that's all we have for today. And here are our references. Does anyone have any questions? I know we are like almost out of time here, but
there was one in the chat earlier that I had missed about clarifying whether or not the diaphragm is voluntary, because McCoy says voluntary, and that always throws us off a bit. She said it was a direct message, I think. So I would say the diaphragm is, we could say, semi-voluntary. I mean, we know that it is always moving. Like, you can't turn it off. It's kind of impossible. But if you allow it to do its thing a little more, if you allow it to descend a little more, sure, you can control its movement a little bit. But voluntary and involuntary are words made up by humans. So,
and it can be damaged by like nerve damage or something like that, and weakness. But that would be a whole other problem that you would be experiencing a lot of other difficulties with, and you should be checked out medically for that. And
oh yeah.
But generally speaking, yeah.
Hemiparesis of the diaphragm is no joke.
Mm-hmm.
Any other questions?
I have a question. If, especially in the new age of online voice lessons being so common, is there a way for voice teachers who have a special interest in working with patients in recovery coming out of voice therapy, wanting to go into voice lessons, is there a way for us to become known to clinics who would be doing referrals like that?
Oh,
what's the best way to build those relationships?
That's a really good question.
I feel like that is uncharted territory at the moment. I think that anybody who reached out with that interest, we would be like, let's get lunch, like, let's just build a relationship. I don't know that there's a formal pathway, but we're all just people, and we would love to have voice teachers to send along to that, and that we could talk about this kind of stuff and get to know people's expertise and just know where to send people, know it will be a nice fit. That would be great.
Yeah. Totally agree.
Does that answer the question at all?
It does. It's just sticky territory with the singing voice specialist designation not really being a formal path of study. And for those of us who might have doctorates in singing voice, but we don't have master's degrees in speech language pathology, but we're interested in a lot of the same things, it's just hard to to establish credibility,
Yeah.
especially if you're brand new, if you're like, hey, I'm here, I'm available, these are the trainings I've done, or this is my background,
Right.
to make sure that, because you of course don't want to refer any of your clients to someone who isn't vetted to you. And so I guess I'm just asking for ways to ease that process, or just cold call. We can also do that, just cold email, send our materials out, and just network the
Yeah.
old fashioned way. Yeah.
Yeah,
Yeah.
like
I mean,
sort of like a networking sort of thing. I know that it would be wonderful if there was some sort of standardization for, a vocology or voice thing that people could do. Sadly, there's not one currently, but yeah, I think maybe just networking and building those relationships so that people just know that you're there. Um, but yeah, you're so right. It is tricky.
I love that everybody who's like here, like we know your names now. That's so nice. If you were to like reach out to me by email, I'll be like, oh yeah, like I saw her in the thing. That's so great. And just like knowing that you're a member of the Voice Foundation and what you've done. And it is such a there is a little bit of I will say, I don't know if you said this already, Jacob, because my dogs were barking really loud. There is like a little bit of a stir about the idea of becoming a SLP assistant. That is not a thing here in Alabama right now as much, because in Alabama, in order to become an SLP assistant, you have to have a degree in communication disorders, which is insane. So there's some movement on the ground about getting that changed, because I think that there have been people in other states who are voice teachers who've gotten an SLPA accreditation in order to work in voice centers, and in order to be that recommendation. So things are always changing. Lobby your senators, my friends.
There was another question that came into the chat from Leslie Murray. Do you work with elderly patients over 80 years, for example, who've been singing all their lives but are having issues related to aging?
Yes,
Yes,
that is.
absolutely.
Oh, that's like our bread and butter. I got to tell you, that's our favorite. Dr. Hapner has an entire program that that has been published and extensively researched for aging voice. And we use it for our singers as well. But we also, sometimes I'll kind of build on the principles of that more exuberant voice training, to create personalized singing voice programs, which is really fun.
Art meets science, one might say.
Oh yeah.
I have a question. So you just kind of dropped the SLPA. You were saying there are voice teachers that have, I guess, degrees in SLPA. Is that referring to the SLP assistant degree that's offered in other states that's not offered here?
Yes.
Correct.
Yes. Yeah. SLPA is speech language pathologist assistant. And it is like, there's like a certain amount of courses that you have to take, but it's really not that extensive, honestly. It obviously costs money, and it's a degree. But it's a pretty short course load, but just it varies by state what the requirements are by your undergrad. And so in Alabama, there, like, the pathway for anyone in this meeting to do that is not paved. So we got to try and pave it. That'd be so cool.
Well, it is. I just watched an old Nats chat about singing voice specialist and their route, I guess, to get there, and in every single one of them was different. And there was no route, but they all, I guess, all kind of considered themselves singing voice specialist in a way. Some just kind of got under an otolaryngologist, some got under an SLP, some got their degree in SLP, and so it's kind of interesting how there's a lot of routes. There's just no clear path.
Yeah. You can, yeah. And I think, I mean, one of the biggest issues with that, right, is billing. Like it's a billing issue. So because we have degrees as like we're certified to do other things as well as doing singing voice. Like we don't even have a formal designation as being a singing voice specialist. We are just speech pathologists. At the moment, the voice specialty is something that's still, there's a lot of work to create it in ASHA, but it is not in the Association of the American Association of Speech and Hearing. But it doesn't exist yet. Like there's a swallowing designation. There's a oh gosh, I forget the other one.
Fluency, child
Yeah.
language.
Yeah, but they're still working to get the voice one. It looks like it's going to happen though. So that's kind of in the works and seems to be like almost a slam dunk. But you know, we're like technically medical professionals. We can bill medically. And so it all just, it's tricky. I mean, all I can say is I'm putting my email in the chat. And if you're like, I have a really big interest in working with voice students who have voice disorders, please send me an email because we need you. Oh my gosh, we need you so much.
I want to ask one more since I'm already here.
Yeah.
Out of curiosity, in terms of the patients that you do see, do you have more, we'll say, singers or professional voice users in terms of actors, singers, media personalities over others? Or, I mean, because obviously communication disorders are not, they're not specific to just professional voice users, but do you tend to see more professional voice users at the Voice Lab?
We see at the Voice Center, we see anyone who has an issue with their vocal folds. So we don't see somebody who has like aphasia after a stroke, right? Like somebody who can't find words, because that would be like under the wider realm of a communication disorder. We see people who have some sort of pathology or suspected pathology with the larynx itself. So although we do see, Jacob and I specifically have been sort of sent the singers and professional voice users a lot, and Edie as well. And however, I would say it's not like it's like a large, huge portion of what we see. We see singers, but it seems to make up a pretty just proportionate average. I mean, we see folks who've had a vocal fold paralysis because they had an anterior approach cervical disc fusion surgery. We see, people who have just aging voice. We see a lot of aging voice. We see people with muscle tension dysphonia. We see a lot of teachers. But one of the best things about one of my favorite things about my job is the variety in the caseload. Just, it's so much fun.
Yep. Good question.
Anything else? Thank you guys so much. This was
so much fun.
Thank you so much, Jacob and Sarah, for sharing your expertise and for answering all of our questions. Thank you so much to this wonderful crowd that gathered here on a Sunday afternoon. It is hotter than blazes outside, so maybe that helped us. But we're really thankful that you gave up a couple hours here on your Sunday to spend here learning and sharing in community with us through our shared passion for the voice. And let's just give a big round of applause to Jacob and Sarah. Thank you very, very much. This was absolutely fantastic. And we're so, so thankful. So this meeting will be recorded. So any of your friends and colleagues who are not able to join us today will be able to catch it on YouTube. So look out in your emails for that link. And we'll be sharing on social media as well. So thank you once again from the Alabama chapter of the Voice Foundation. Thank you all for being here. And thank you to our guest speakers. Have a good night, everybody.